Assalamu alaikum. Hello and good evening to the ACPN Patient Headache webinar series. This is the first webinar series in a series of 6 that is organized and arranged by the American Center for Psychiatry and Neurology. The day is 7:30 and it's the 17th of February 2021. My name is Gerard Moore and I am the webinar support manager for today, and I will also be hosting the questions and answer sessions afterwards. This is a patient forum, so please feel free to post any of your comments or questions for our speaker that we will then put forth after his presentation. You can find the chat box on your right hand side and you can type anything there. If you wish to remain anonymous, you can write to the admin only button and I will receive your questions privately. Also, if you experience any video or audio issues, you can press the red reconnect button that is located at the top of your screen, and that will resynchronize your webinar. Our speaker today needs no introduction, but I'm sure most of you know him. His name is Dr. Taoufik Saadi. He is the Chief Medical Officer and Consultant Neurologist and Chairman of the Neurology Department at the American Center for Psychiatry and Neurology. Today he will be discussing for you the session titled Understanding Your Headache Diagnosis. Dr. Taoufik, the floor is yours.
Good evening. Thank you very much, Gerard, for the introduction. On behalf of the CME Educational Committee and the Senior Management Team of the American Center of Psychiatry and Neurology, I would like to welcome you to our first session of series of sessions that directed towards our community, to our patients that we love, and addressing some of the important issues that we face in our everyday life, specifically when it comes down in relation to headaches. And as you will see in the coming slides, headache is one of the most important neurological complaint that we face in our everyday clinics. And I'm sure all of you either had or have heard of someone who had experience in your family who had experienced headaches, and you all have these questions about how to manage patients and how to deal with patients with headaches and come up with the right diagnosis and the right approach of management. We as American Center of Psychiatry and Neurology, since we were established back in 2008, had a clear vision to be the leader in the field of neuroscience and mental health and to provide the highest quality of care to our patients, to our community in the setting of education. And obviously hosting these series of webinars and educational activities is a testimonial to our support to our community, to our patients. And this is again the kickoff of the series of meetings that we're planning to do in the coming few months to address some of the important questions that you all may have in your mind, especially with dealing with some of the most common neurological disorders that we face in the community. I would like also to thank the sponsor for the event this evening. And today what I will be talking about how to understand patients who come to us with a diagnosis of headaches. Let me start with some basic epidemiological data. It is believed that at least 80% of the general population have experienced some type of headache at one point in their life, meaning 80% of the population may at some point in time had experienced headaches. And 30% of the population would suffer headaches that would require some sort of treatment. And we all know this, and especially for the people who are practicing in neurology or even for general practitioners, that headache is one of the most common reasons patients would visit their physicians. If you look at global estimate of the headaches in the globally, you find that the prevalence of headache is around 47%. But of the all types of headaches, migraine is the most prevalent headache subtype, where at least 1 in 10 person globally would have migraines, regardless where you live or where you practice, being in Europe, South America, or in Asia, or in our region, at least 10 to 15% of the general population would have a migraine headache. Now, when we talk about headaches, we have to understand two main subcategories of headaches. The first important one, because it's the most prevalent one, it's called primary type headache. So when I call it primary, it means that patients with primary type headaches, they would have a normal neurological examination, normal MRI or any other imaging studies of the brain, but they have headaches, meaning they do not have any other reasons why they have headaches. There is a component of headache, but their exam, their imaging studies are all normal. And the most common subtype of the primary type headaches are tension type headaches or migraine headaches. On the other hand, the less common subtype of headache is called secondary type headache, when there are secondary causes of headaches. For instance, God forbid, if you have a brain tumor, you may have headache that is called secondary type of headache. Or if you have inflammation of the brain layers or meninges, we call it meningitis, then that would cause headaches. So that's an example of secondary type headaches. Generally speaking, of all the headache types, 10% of the headaches are related to secondary type headaches. So that means when someone comes in with headache, 9 out of 10, we are dealing with a primary type of headache. And 1 in 10, we are dealing with a secondary type of a headache. Now, if we specifically look at patients with migraines, and this is the data from the United States, where we know that at least 30 million people in the States would have migraines. Overall, the prevalence of migraine is around 12 to 13%. Unfortunately, it is 3 times more common in women as compared to men, where the prevalence in women is around 18% as compared to 6% in men. The problem with migraines that it tends to peak in the years of productivity, meaning in patients in their 20s, 30s, or early 40s. And again, as you can see in the slide, 3 times more common in women as compared to men. Now, if you compare the prevalence of migraine as compared to other chronic medical conditions, and we give example here of patients with diabetes, asthma, or osteoarthritis, you can easily find out that patients with migraines are far more prevalent as compared to patients with asthma, diabetes, or osteoarthritis. Now, the big question that we face every time we see a patient with headache, how can you make the diagnosis of headache? Well, simple, history. So the most important element in making the diagnosis is history and doing what we call the physical and neurological examination. And in the history or in the exam, we look for what we call it red flags, meaning there's something suspicious in the history or the red flags that we as physician would dictate to us that we need to do additional testing. So if in the history or the physical exam there were no red flags, then we are dealing with a primary type headache, either migraine or tension type headache. And remember, 9 out of 10 of all headaches are primary type headaches. Where on the other hand, if there are evidence of red flag, then we are dealing with secondary type of headache, and that would require additional testing, like for instance, MRI of the brain or CT scan of the brain or a blood test. But again, if there are no red flags, then 9 out of 10, we are dealing with a primary type headache. On the other hand, there are a list of 3 questions that we can ask at the level of the clinic, and by answering these questions, the physician, regardless of his or her specialty, can make the diagnosis of migraine headache, for instance. And these questions are: were your activities limited for more than 1 day over the last 3 months? Were you nauseated or sick to your stomach? Did light bother you? if the patient answer any of these questions, 2 of the 3 questions, by saying yes, then you have more than 95% chance that you are dealing with migraine headache. So very simple questions that any physician can administer at the level of the clinic. Then by more than 95% of the time, we can make the diagnosis of migraine headache. The problem with migraines in general, that it is heavily underdiagnosed and undertreated. And oftentimes I see patients coming to the clinic with a diagnosis or presumed diagnosis of sinusitis, which is inflammation of the sinuses, or because of ear problem or teeth problem. That's what they think, at least, or they claim. But it turns out they had migraine headaches. So migraine headaches, unfortunately, still heavily underdiagnosed or treated. And the reason I'm mentioning undertreated, because if you look at this slide, 50% of patients with migraine are receiving over-the-counter medications, meaning they just go to the pharmacy, receive Panadol, ibuprofen, etc. They don't go to the physician and receive the well-advised medications. And as you can see in this slide, 50% of the patients are addressed or diagnosed at the level of their physician. So that means 50% of patients with migraine, they may go walk around and they are still not well diagnosed with that diagnosis, meaning they're receiving the wrong treatment. Now the question, why do you diagnose migraines? Why it's so important? Well, obviously it is a highly prevalent disorder. At least 1 in 4 households would have migraines. It's a costly disease, and most of the costs for caring for a patient with migraines come from loss of productivity. And as you can see from this slide, 1/3 of women and 17% of male migraineurs, meaning patients with migraine, would miss 6 or more work days per year. So loss of productivity. So it's a costly disease, highly prevalent, and that's a call why we have to address and diagnose patients with migraines. The other thing that to keep in mind, and due to the severity and the burden of the disease, the WHO, World Health Organization, had rated migraines along with quadriparesis, psychosis, and dementia as one of the most disabling chronic disorders. So it's quite a disabling condition, because at least 50% of patients with migraine would have attacks that would require bed rest. So half of the patient with migraine may have attacks that would require bed rest. So that basically indicates how severe the patients with migraine may suffer because of the severity of their attacks. If you look at what we call the global burden of the disease based on the recent data that was published a few years ago, and you can see very clearly here that migraine comes next after low back pain as one of the most leading cause of disability. But if you look at the patients group between the age of 15 to 49, meaning those with productive years, we find out that migraine takes the lead. So migraine is the leading cause of disability in the population of higher productivity. And that's quite alarming. And that's, again, call for a better and earlier diagnosis for migraine, and specifically for that population. And as you can see from this slide, at least 25% of patients with migraine would have 4 or more attacks per month that would require bed rest or attention or medical treatment. Now, what about the phases of migraine? Does it have a specific phase? Well, that, as you can see from this slide, doesn't obviously apply to each and every patient, but it can go on phases. The first phase, which is called the prodromal phase, which are the symptoms or some feelings patient may have before the kickoff of their migraine attacks, which usually starts a day or a few days before the start of their headache, which call it the prodromal phase. Then in about 25% of patients, they would have the aura, which is some sort of feeling, which we'll discuss later on, before the actual headache starts. And then they have the headache phase. and they have what we call the prodromal phase, which is the time after the headache. But obviously, not every patient would have these 4 phases. Some would have only aura, may not have headaches. Some would have headache without the aura before. Some will have the prodromal phase, some may not. So not every patient is the same when it comes down to these phases. But it's very important to keep in mind the phases of migraines. What about the prodromal phase? Well, it turns out that at least 2/3 of patients with migraine would have some sort of premonitory phenomena that precedes the onset of their headaches. And at 25% of the time, patients with migraine would tell you that I feel depressed, hungry, thirsty, or drowsy a day or two before the headache starts. And we can divide these symptoms either excitatory symptoms. So patients will tell you that a day or two before their headaches, they feel irritable. They will be craving for food, and that would explain, for instance, why some food items had been linked to aggravating migraines, probably because patients a day or two before the headache start would be craving for food. There would be, again, some of them may complain of yawning. And other patients, they will have inhibitory symptoms. So they will tell you that a day or two before the headache, they will have difficulty concentrating. They will be having some word-finding difficulties. They feel down. They feel slower than usual. Again, that usually starts a day or two before their headaches. 25% of patients would have an aura before the headache starts. So the aura is basically a set of neurological symptoms or signs which basically reflects some activation at the level of the brain or brainstem. Some of these auras, I'm sure you all have heard of this, visual auras. So a patient will complain of some scintillations, some zigzag lines, some scotomas in one of their eyes before the headache starts. They may also complain of numbness at one part of their body or the other. But usually these symptoms would last anywhere between 20 to 60 minutes, and then it slowly go away, and then will be followed by a headache. Now, what about the headache phase itself? And that is the most important element to making the diagnosis of the headache, specifically in patients with migraine headache. Because the main issue that we face in diagnosing headache, especially when it comes down to managing patients with primary type headache, differentiating migraine headache from tension type headache, how we can distinguish between the two. Well, in patients with migraine headaches, the headaches would be of moderate to severe in terms of severity. It can be unilateral, but that's only in 2/3 of patients, meaning in 1/3 of patients, the headache may be generalized, may not be unilateral. It can be pulsating, like the heart rate, but more importantly, the pain is aggravated by any normal physical activity. It can be associated with nausea, vomiting, photophobia, meaning the patient will fear light, phonophobia, meaning noise, and they tend to go to sleep in order to get rid of these symptoms. So the best way to distinguish headache as in relation to migraine as compared to patients with tension type headache, that patients with migraines, most often they would be able to function during the time of their headaches. They have to lay still, turn off light, avoid noise, and any activity may worsen the headaches. Whereas in patients with tension type headache, most often they can carry on with their daily routine without any restriction. And that's the best way distinguishing migraine from tension type headache. Now, after the headache is over, then patient may suffer from, in a day or two, what we call post-headache phase. So they have some mood changes, and at least 70% of the time, they either feel depressed or irritable. They may feel weak, tired, or they may lack appetite in about a third of the patients. And these symptoms, again, tend to last anywhere between a day to two, occasionally up to 3 days, and then it will go away. Another thing to keep in mind, again, just to alert everyone why it's important to make the diagnosis and start on treatment, because migraine can be a progressive disease. And there are some studies suggesting that at least 4 to 5% of the whole population may have a chronic daily headaches. And of those, 70% of the causes of chronic daily headache is the transformation from episodic migraine, meaning patients that have attacks of migraine, to becoming a chronic headache, meaning that they have almost continuous headaches. So migraine can be progressive if not adequately treated. And the big question, what are the factors or the issues that we need to be aware of that could put our patients at risk of going into that progressive chronic phase? The number one factor that we need to be aware of is the attack frequency. And we'll see later on a slide on this, that the more frequent attacks the patient would have, the more likely they go into that chronic progressive phase of the disease. The acute medication overuse, if patients, because of the severity of the attack, start to take more and more painkiller, then they are more likely to go into that progressive phase. The duration of the disease, the longer the migraine, the more likely patients will go into that progressive phase of the disease. And obesity, I'm sorry for the people who are a bit overweight who are attending this webinar, but obesity is one of the factors that could put our patients at risk of going into the progressive phase of the disease. And finally, stress. Stress is a big factor, not only to provoke attacks, but also to put our patients at a risk of going into progressive phase of the disease. This is the study I was alluding to, that this study was done in the States, looking at 450 patients with history of episodic migraine. There were patients who had frequent attacks of migraine. Of those patients, 14% had developed a chronic migraine, so they went into the progressive phase of the disease. And if you look at the important of the risk factors that had led these patients to go into the progressive phase of the disease, the frequency of the attacks. So patients who had 10 to 14 days with headaches, they were at least at 20 times more risk to go into the progressive phase. Patients who had 5 to 9 days of headaches in a month, they were at 6 times more risk of going into the progressive phase of the disease. And patients who are using too many of the painkillers, they were at 20 times more risk of going into the progressive phase of the disease. Again, emphasizing the importance of addressing the frequency of the attacks and the importance to limit the number of use of painkillers in order to prevent our patients from going into the progressive phase of the disease. And that will take me to the important point about how we can, generally speaking, how we can set the stage to manage patients with migraines. Generally speaking, the most important aspect of managing or treating patients with migraine is education. Education. So you need to educate the patients about the type of the headaches they have, how we can best treat it, what to expect, what treatment to start on, the duration of treatment, and what to expect from that treatment. It's very important. Obviously, it's not the scope of this webinar to talk about treatment, but I just want to give a few points here because that's very important to understand how to manage patients with headaches in general, especially patients with migraine headaches. That when you start treatment for patients with migraine headaches, or even for patients with tension type headache, we're not aiming for a cure. We're not going to be able to cure your migraine. I'm sorry, we don't have a treatment yet to cure your headache or to cure your migraines. But what we can do, we can control your headaches. We can make it way much better. We can certainly reduce the severity, the frequency of the attacks, make it quite infrequent, and it may go away for some time, but we're not going to be able to cure your headaches or your migraine headaches, because we don't have that treatment yet, but we can certainly control your headaches. The second point, we have always to look for trigger control. Patients with migraine, oftentimes they have some triggers for their migraine. So we always have to ask our patients to identify what are your triggers for your migraine. Is it a specific item of food or drink that trigger your headache? Is it a specific stress factor that triggered the headache, or are there any other factors? So it's very important to identify the list of triggers that would put our patients at risk of going into breakthrough headaches. Behavioral modifications is always important for patients with migraine, to make sure they have good hours of sleep, good hydration, minimize the use of computer, laptops, cell phones, although I must say this is quite difficult these days because unfortunately our world since the beginning of COVID-19 pandemic turned to become quite virtual, and we cannot obviously work without the internet or the computer or cell phone these days. But what we can do, we can at least control that, minimize the time we spend in front of our computer, laptops, or at least make sure that we take a break between sessions or between webinars or between meetings. It's very important. And finally, and that's obviously something you need to discuss with your physician, pharmacological treatment. And there are two main components of the pharmacological treatment: acute therapy, meaning if you have an attack, the drug that you need to take at the beginning of the attack. And I always recommend migraine-specific acute therapy, so a drug that you take at the beginning of the attack. And in some patients, especially for those who have frequent attacks, to start on something we call it preventive treatment or prophylactic therapy to prevent the recurrence of these migraine attacks. Now, if you look at the slide, this basically summarizes to all of us what are the triggers of migraine attack. And not surprising to all of you that stress is a big one. 80% of the triggers are related to stress. For women, hormonal fluctuations. That's why, for instance, in women, we'll find worsening migraine around the menstrual cycle or the time they start taking oral contraceptive pills. Weather changes, sleep deprivation, and that could be a big problem, especially for shift workers. So sleep deprivation is a big factor. There are other issues that we need also to pay attention to, such as certain food items can or may trigger migraine attacks. Heavy exercises in some patients may also trigger some attacks. So keep in mind, it's always important to, if you have an attack, go back and see what was it that you were doing before the occurrence of that attack. Was it a certain food item, a specific drink, some exercises you're doing, or whatever that had triggered the attack? Was it because you were not sleeping well the night before? Were you tired? Were you sitting in front of your computer for long hours? What was it that had led to that acute attack? Then you can try to at least minimize it and prevent further attacks. Despite all what we do in terms of education, the importance of treatment, etc., this is obviously the data that was obtained from the United States. Despite all what we know, there are still a significant proportion of patients that are identified as good candidates to start on prophylactic treatment or preventive treatment, but only 10% or so, meaning 1 in 10, are receiving preventive treatment. And that's actually a call to educate all of us, healthcare providers, patients, that if you have frequent attacks, you need to bring it up to your physician because you could be eligible or candidate to start on preventive treatment and preventing the disease from progressing and going into the chronic phase of the disease. One thing to keep in mind as well, that oftentimes patients with migraine have other comorbid conditions, meaning they may have other diseases that can be associated with migraines. Specifically, what we see with patients with migraine, oftentimes they may have other cardiovascular disorders, most commonly hypertension, occasionally stroke, asthma, and also depression. Depression is quite prevalent, as well as anxiety in patients with migraines. And the importance of addressing these comorbidity factors. If any of us had migraines and had one of these comorbid conditions, let's say, for instance, depression or anxiety or panic attacks, and if you don't address these comorbid conditions, if you don't treat the depression, you don't treat the anxiety, or you don't address it well, then we as patients, or you, would not respond to treatment that well. So it's very important to address these comorbid conditions in order to have the best response to treatment. So with that, I end, and I'll be very happy to take any of your questions, should you have any. Thank you very much for listening to this webinar today.
Thank you, Dr. Taoufik. Thank you very much for a wonderful presentation, very insightful. And I've been monitoring the chat bar, and we've had quite a few questions come in. So I will dive right in the last 25 minutes or so that we have. I will start from the beginning. We have a question here discussing to you about food and the appropriate diets. What's your advice you give to your patients about any foods or any diets that you've seen that helps alleviate migraines, please?
Well, I tell my patients you need always to look at your diet, and you have to pay attention what sort of food can trigger your migraines. And I can tell you, based on my experience with patients with migraine, every patient is different. So what trigger migraine for that particular patient may be different from other patients. But generally speaking, there are some certain food items that may, not in every patient, may trigger migraine attacks. For instance, nuts, spicy food, chocolate in some patients, cheese may in some patients, not everybody, meaning that you shouldn't cut off on all of these items just because I mentioned them. You have to see if any of these items provoke or trigger headaches, then you need to avoid them. In some patients, they do trigger attacks, and others they may not. But these are the most common items that I typically see in my practice. I repeat, aged cheese specifically, wine for people who drink wine, nuts, spicy food, some of the chocolate in some patients may trigger migraine attacks in some, but again, not in every patient.
Thank you very much. We had a private question. I believe you mentioned it in one of your slides, but I think they're asking for you just to repeat it and clarify some points. Key triggers or red flags to look out for. Can you just kind of explain a little bit more on that slide, please?
Well, the red flags are basically the flags that should be picked up by a physician. But obviously, I'll be happy to discuss it with all of us here in this evening. For instance, I'll give you an example. What I mean by red flag. Let's say if you have a typical migraine attacks of certain severity, and suddenly your headache had become quite severe, unusual, different from your typical headache. So anything different from your typical headache, that is a red flag. So if you had a certain pattern of headache, but suddenly the pattern had become different, it is now quite worse. Now you start to have other features with the headaches. Let's say with the headaches now you start to feel a bit weak on one side, you had heavy numbness on one side or the other, or you have other associated symptoms that you did not have before, that is a red flag. If, for instance, a healthcare provider do perform an exam on a patient and he or she picked up some abnormality on the exam, let's say weakness on one side of the body, some focal finding on the exam, that is a red flag. So any change from normal in a patient with headache is a red flag.
Thank you.
Whether it's picked up by a physician or if reported by the patient.
Thank you. We do have lots of questions coming in on a variety of topics, and I will remind the audience that this is the introduction webinar. We're having 6 of these at the moment that will go into various topics of migraine. So related to women's health and other matters, mental health. Dr. Taoufik will try and mention them in brief now, but there'll be in detailed ones in those regards later on, but we will cover those at the moment. But just bear in mind that we can't go into great detail of those at this time, and that leads me actually onto this. This is a two-part question. Just please tell me about birth control pills affecting headache during my cycle. What can I do? And then I think the second part is, should I be taking pharmacy bought drugs? I think she means over-the-counter medicine. So I think a two-part question there, one about birth control and cycle, and then one about
over-the-counter medications. Yeah. Well, regarding the birth control pills, it's well known that birth control pills, especially those that are heavy in estrogens, are big triggers for migraines. So if you have migraine headaches, it's always important to mention to your doctor that you do have migraines. So what the doctor would need to do, either use a different method of contraception, and that is preferable, or if you are to use oral contraception, contraceptive pills, then they can prescribe the medication that have a lower level of estrogens, because the higher estrogen in component in your oral contraceptive pill, the more likely that would worsen your migraine. So it's always important to discuss that with your physician, to either use another method of contraception or to use a lower estrogen component of oral contraceptive, or using progesterone only oral contraception. So always important to discuss that with your physician in order to avoid it. Now, regarding the over-the-counter medication, I advise you not to, because as I mentioned earlier, one of the problems we face in managing patients with migraine, half of the time, patients are just going to the pharmacy, getting over-the-counter medication. That is a very wrong practice, because if you keep using over-the-counter medication, number one, you're not controlling your headaches, and number two, you could expose yourself going into the phase which we don't like to see, which is called medication overuse headache. And remember what I said earlier, that if you go into that phase, medication overuse headache, then you're putting yourself at the risk of going into the progressive nature of the phase of the disease, or the chronic phase of the migraine headache. So we don't want you to go to that direction. So it's important to limit the use of over-the-counter medication unless it was advised or prescribed by your physician. Otherwise, I would never advise you to go to over-the-counter medication.
Okay, thank you for clarifying those points. The next question that has come in is, what are your thoughts about alternative therapies, hypnosis and herbal products? What is your advice on this?
Well, complementary therapies or alternative therapies are always important to manage many neurological conditions. Obviously, headache is one of them. But these are always complementary, meaning drug therapy should be the main goal of treatment. Other modalities, especially the ones that have shown some good evidence of efficacy, can supplement these therapies or these medical therapies. The things that we have seen so far that have a proven efficacy in terms of patients with migraines or patients with headaches in general: relaxation technique, biofeedback, yoga therapies are some of the important therapies that we can use to supplement, again, not to use by themselves, to supplement medical therapies. Herbs, certain herbs are used and have shown some good efficacy based on some data. So I always advise, if you're going to use herbs or you're going to use any of the other vitamins for managing migraines, consult with your doctor. For instance, I'll give you an example. Magnesium. Magnesium has shown some good efficacy data of its efficacy based on several class 2 evidence of data, so that can be used. But not every vitamin can be used. Any vitamin that to be used need to be discussed with your doctor, because not every vitamin have good efficacy or good data that suggest their effectiveness in managing patients with migraine.
Thank you very much. Next question that's come in is, I get pain in my neck and back during headaches. Is that common?
It is very common. It is very common. And indeed, many patients turns out that they have migraine headaches. They come to our clinic thinking that they have a neck pain, and they have a cervical disc, and turns out they have migraines. Because what happens during the migraine attack, especially if the migraine attack of certain severity, the attack itself may start from the head and then spread back to the neck, shoulder, or the arm, or it may start from the neck and spread up to the head. So either way, so neck pain is an important component of the headache phase itself. And as I mentioned earlier, oftentimes patients come to us with a claimed diagnosis of cervical disc, and turns out they have migraine headaches. So be aware of this. If you have neck pain, it may not come from your neck. It may just come because you have migraine headaches.
Thank you. Very interesting. This next question, I know it's not about medications or treatments, but I'm sure some of the patients here are very keen to know about the latest new medications that are out. This gentleman's asking about what new treatment would I know is best for me. So do you want to maybe elaborate on some of the new medications that are out very briefly, even though it's a non-commercial webinar?
Well, again, we're not going to mention drug names here, but I can tell you that the big advances that we had in the field of migraine, number one, now we start to understand migraine in a better way than we used to many years ago. So at least we know what happened during the migraine attack, what could trigger migraines, and we know what is the best drug to treat patients with migraine. So in terms of acute treatment, we have several new classes of treatment that are available to treat patients with migraines, because until just recently we had only the old drugs that we had used to treat attacks of migraine, and some of them are unfortunately associated with some side effects. So now, at least with the two new classes of acute treatment, migraine treatment, these drugs are quite safe, well tolerated, effective, and they don't have the side effects that we used to see with the old drugs. That's for the acute treatment. Now for the preventive treatment, which I mentioned earlier, that's quite important and essential in managing patients, especially for those who have frequent attacks. Now we have a new class of treatment that target the exact pathophysiology of migraine. We call them the CGRP inhibitors. So they work exactly on the underlying mechanism of migraine in order to have a better control of their migraines. And these are injectable medications, which again, I'm not gonna mention the commercial names of these drugs, but we have now better drugs to understand the headaches a better way and try to address some of the unmet needs that patients with migraine often have.
Thank you very much. This next question, again, it's relating to women's health, and I will obviously implore the audience that we will be having a dedicated webinar on this matter later on. So, but Dr. Taoufik will of course answer it, but there will be a more detailed webinar coming later. The relationship between pregnancy and migraine, and do pregnancies trigger their migraines that you see?
Very good question. It varies. I can tell you 50% of the time, the migraines would get better during the pregnancy, and about 25% of the time it can become worse, and about 10 to 15% of the time would remain the same. So there's a chance that your migraine may get worse. There's a chance that it may remain same as it was before the pregnancy state, and about most of the time it will remain. It will basically become better during the pregnancy state itself.
Thank you very much. Another question here is: can you explain the difference between sinusitis, migraines, and other headaches? How I can tell the difference?
Well, sinusitis has a typical features. The headaches will usually be around the sinuses. Patients would have other features such as discharges from their nose, whereas in patients with migraine, they would not have these discharges. The pain with sinusitis will be again around the sinuses itself, where pain in migraineurs would be again unilateral in about 2/3 of the time, or generalized in about 1/3. They will have strong photophobia, fear of light, whereas in sinusitis, they will not have that fear of light or noise that we typically see in migraineurs, but we don't see it in patients with sinusitis. Plus, the sinusitis tend to worsen with certain position. So changing position would or trigger or worsen some of their headaches, and that you don't see in patients with migraine.
Okay, thank you. That is the public questions over for now, but we do have some private anonymous questions which I will ask you now. For those that wish to write any public questions, you please feel free to do so on the chat bar while we move to the anonymous questions. This one here is more on a personal level. My boss does not believe that my headaches are crippling in nature, and it's affecting my work. What can I tell them, or what can I do to explain the severity of my condition?
Ask your physician or treating physician to write you a letter or a report to emphasize the importance of how migraines had been affecting your work, your social life. It's very important to have that discussion with your boss, because most of people at work may not understand how migraines can negatively affect the patient's overall life in terms of productivity or even social life. So always communicate that with your physician, and I'm sure your physician would be willing to help you write a report to emphasize how migraine had been negatively affecting your life.
Thank you.
And we can support it always by data to support your physician's point of view.
Thank you very much. Should I keep a diary, and what should I keep in the diary?
Well, it's very important to keep a diary when you have a history of headache in general, or especially in patients with migraine. In that diary, it's important to document how often you're having migraines or headaches in general, and what were the trigger of your headaches. So, because that will be important teaching point to avoid further attacks, and the duration of the attack, and what have you done to manage your attack. What sort of pill you took to treat your attack. Did it work or not? So the number of attacks, the duration, what medication you used, did it work or not, and what were the triggers before your attacks. These are the important points that you need to document every time you have a headache, and that will help your physician understand your headache better and try to meet your needs and address your concerns.
Thank you. What exercises do you recommend to assist with headaches?
Generally speaking, relaxation exercises, yoga have shown that is quite useful in terms of reducing the frequency and severity of the attacks. So gentle exercises in general is good for your migraine headaches.
Okay, thank you very much. And the final question here is, you've mentioned it's actually in one of your slides, but this person asking, in the future, can you foresee any cure or any way that we can completely eradicate migraines?
Well, obviously, we are advancing in our understanding of migraines. What we know now about migraines, we didn't know obviously 10 or 15 years ago. Now we have a better understanding what are the triggers of migraine, how to best deal with patient with migraine, how to better manage patient with migraine, and try to improve the overall quality of life in patient with migraine. So clearly we have seen a major breakthrough in understanding and managing patient with migraines. So yes, I see a hope that we at some point in time, we may be able to reach a point where we make your headache, cure your migraine. But at least at this stage, we have better tools to address your needs, meet your expectations, and better control your headaches.
Thank you very much. We will just leave a couple more minutes for anybody that wants to write any questions. Please write them now for Dr. Taoufik. In the meantime, we will just draw your eye to the calendar of events which will be running. You can see obviously the first one today with Dr. Taoufik, how to understand your headache diagnosis, and then Wednesday, March 17th, we will have our second one, which will be know the most effective approaches in managing your headaches. That will be followed by managing migraines during fasting on April 7th. After Ramadan on May 26th, we will have the women issues and family planning. And then lastly, the final webinar will be the mental health webinar, and that will be on June 16th. So you are registered now. You are registered for all of the upcoming events. No need to re-register, and you'll be sent a link accordingly during those times. And this webinar has been recorded, and you can watch it back for the next 7 days. And then I believe we'll be posting it on a more permanent platform to come later on. I do not believe there are any more questions. Dr. Taoufik, I will hand back to you for your closing comments, please, for today.
Again, thank you very much, Gerard, for hosting the event. I'd like to thank you all for attending this webinar. This is a kickoff of the series of education activities that we plan to do in the coming few months. Try to address one of the most important neurological symptoms that we do face in our clinics, and I hope that these webinars will address your concerns, your questions, and please stay tuned for further education activities that we plan to host at the American Center of Psychiatry and Neurology.
Thank you. Thank you, Dr. And just where can they find you if they want to book an appointment with you? How can they reach you, Dr. Taoufik?
Call 800 ACPN, 800 ACPN, and book an appointment, and we'll be very happy to meet you and try to address your concerns and try to settle your issues as soon as possible.
Thank you very much. Thank you, Dr. Taoufik, and thank you all for the audience that attends. And we will send you the link for the recording, and then we will keep you updated with our upcoming events. Good night, all. Thank you.
Good night.